afternoon, everyone. Welcome to Yashoda Hospitals webinar series with an absolute aim to set a new benchmark in the healthcare industry. Yashoda Hospital has been excelling in providing quality healthcare services last 3 decades. Critical care nursing is a challenging responsibility and yet is highly rewarding. Critical care team need to be highly vigilant all the time, and they should be having sound knowledge about equipments like ventilators and life-saving equipments. So all those things keeping in mind, we thought to have topic today. We selected on basics of mechanical ventilations, modes, alarm, and troubleshooting for nursing. So if they know these basics, and we try to make it very simple so that they can follow us on this webinar series. We covered mostly basic modes as well as the what ventilator related events, how to troubleshoot that. And we try to concise it in a very simple way. Today's panel, I welcome Dr. Abhishek. He is our senior consultant intensivist. He is working with us since long time. And I welcome Ms. Yojana. She is our senior staff nurse working with us last 10 years. And she is certified critical care nurse. So I would like to welcome and ask Ms. Yojana. Please take over and start the webinar series.
Thank you so much, sir, for your introduction. So myself, Yojana, I'm a nurse educator working in Yashoda Hospital. Coming to a mechanical ventilator. Mechanical ventilator. So during the COVID pandemic situation, everyone from the youngest to the oldest know what is a ventilator. But why a ventilator is used, and what is the purpose of using ventilator? What does it do? And who requires a ventilator? So does it make a difference about knowing a mechanical ventilator for the common person and for a nurse? Yes, we do require a mechanical ventilator, and we need to have a knowledge on mechanical ventilator. So in this session, I'm going to explain about in which conditions or what is a mechanical ventilator, why we are using a ventilator for the patient, what are the initial settings of ventilator, the difference between the volume and pressure control, the different modes of the ventilator, red flags, that is a warning signs, and its management like ventilator alarms, VA bundle, complication. Let's see what is a mechanical ventilator. A ventilator is a machine that helps the patient to breathe. During a normal respiration, we have inhalation and exhalation. When a normal person, like without any disorders, are taking an oxygen during inspiration. So when you are inhaling, so what happens? The diaphragm, the muscles of the thoracic cavity will pull the air so that the alveoli are getting oxygen, and there is an exchange of gases, and carbon dioxide will release. When a patient is not able to do this mechanism, then they require a ventilator. For example, here in this video, so this is a ventilator. When a patient is not able to manage, or when a patient is not able to ventilate himself, we are connecting a patient in a ventilator. So what this is doing? So it is pushing the air that was preset by the operator. When it is pushing, so this air will enter into the lungs, and it will be here. It goes into the alveoli, and then oxygenation happens, and carbon dioxide will come out. So this is a mechanism that is happening for patients who are on ventilator. So is it clear about the mechanism of ventilator? Next, we'll see the indication. As I told you before, when a patient is not able to exchange the gases in the lungs, and also if the patient is not having any lung volume when he is inspiring, then we will go with a mechanical ventilator. So when the disease conditions, in the disease conditions, we have a planned ventilation and unplanned ventilation. So planned ventilation means if a patient is going for any surgery, major surgery, then it is a plan so that we need to intubate the patient and connect to the ventilator. But unplanned is an emergency situations, like if the patient is suffering with the COPD, they are desaturated, then we need to connect the ventilator, like COPD patient, hypoxemia, patient with an ARDS and CNS depression. Because of this, the patient may have an hypoventilation, and post-operatively, the patient has a respiratory failure. During all conditions, a patient requires ventilation. Then let's move on to when a patient is having an emergency, patient was desaturated and the vital signs are increasing, tachypnea or tachycardia. So what happens? The doctor will definitely advise to connect a ventilator. So as soon as a doctor advised to connect it, it is a responsibility of a nurse to set the parameters in the ventilator. The first thing that you need to set is the mode. So mode, I will explain you in a further slides. So the mode you need to set according to doctor's order. And so I have displayed the different parameters on the screen. So among these parameters, the main three things that I'm going to explain. The first one is a tidal volume. It is very, very important, and it is important for a nurse to set the tidal volume based upon the ideal body weight. That is 6 to 8 ml per kg body weight. The next is a PEEP. So what do you mean by PEEP? Anyone knows what is a PEEP? Tell me in the chat box, what do you mean by PEEP? Anyone? Okay, so PEEP means it is a positive end expiratory pressure. So this PEEP will help the alveoli to open. So open in the sense when an oxygen is taken or when a ventilator is giving a preset volume. So what happens at the end of the expiration, the patients will have a good volume of alveoli. So it will be open. So this will help in opening the alveoli to prevent the collapse of the alveoli during ventilation. So always set the PEEP to 5 to 7 centimeters of water. The rest, next third one is the I is to E ratio. So I is the inspiration expiration ratio. So remember, when you set the ventilator, always the inspiration is lesser than the expiration. The expiration is more than the inspiration. Why? Because so inspiration, when you're taking an oxygen, so expiration, you are washing out the carbon dioxide. If the expiration is set as a low, so what happens? There is a chance of accumulating the carbon dioxide in the alveoli. That's why, so we always keep the expiration the extra amount than the inspiration. So in order to wash out the carbon dioxide in the alveoli. So am I clear with this? Anybody, any doubts? So if you see on the display here, so this is a screen that was displayed on the ventilator. So here, this is a type of respiration that you are setting, a mode of ventilator, respiratory rate, if I were to display here, PEEP, and this is the actual respiratory rate of a patient when he is on the ventilator. Next. So here we have a volume control and a pressure control. So what do you mean by volume control and pressure control? Are they modes of a ventilator? Volume control, pressure control, are they modes of a ventilator? Okay, so they are not the modes of a ventilator. They are the variables of a mode. That means, so volume. So volume means it is a quantity. So quantity, when you want to give a certain amount of gas, so we have a quantity so that we are pushing this into the lungs. That is a volume. So you have a control over how much amount of oxygen you want to give to the patient. And it is from the ventilator, not from the atmospheric pressure. Then coming to the pressure control. So pressure control is the force, with how much force this air has to enter into the alveoli to get a ventilation. Am I clear with the difference between the volume control and the pressure control? Depending upon the patient conditions, the doctors will choose whether the patient requires volume control or the pressure control in the modes. To know the difference, so here in a volume control, always remember the tidal volume will be fixed, and inspiratory time and inspiratory flow will be fixed and vary depending upon the respiratory rate and the flow setting of the patient. Then peak inspiratory volume will be variable. Whereas in pressure control, the tidal volume will be variable and inspiratory flow will be variable. Then peak inspiratory flow and inspiratory time will be constant. And here, the peak airway in the volume control, remember that the peak airway pressure is more than the peak alveoli pressure. Whereas in the pressure, both are equal. Then let's see. So what are the modes that you know in a ventilator? Anybody who can tell me about the classification or the modes that you are seeing in the ventilator? We have many modes like assisted control, SMV mode. And so these modes we are seeing, and they are divided into three. One is a conventional mode, adaptive mode, and biphasic mode. So in conventional mode, this is a traditional mode where this is a commonly used in the ventilators, and this I'm going to explain. So in the conventional mode, we can see CEMV mode, assisted control mode, and SIMV mode, PSV mode. Adaptive mode, you can see PRVC, and biphasic mode, BiPAP. So let's see in detail one by one these modes. The first one is a CMV mode. In this mode, nowadays we are not using this CMV mode, but so what is the function is here in the ventilator will deliver the preset tidal volume and respirator. So how much the tidal volume was set and the respirator was set by the operator, this mode will deliver it. And the patient is not giving any opportunity to breathe. Next is the assisted control mode. So here in this mode, here also they will the tidal volume, respiratory rate, and the patients. So this will be delivered by the ventilator. But when a patient is able to trigger, when the patient is able to breathe, so this will give support for the patient to breathe. This is about assisted control mode. Next is SIU mode, which we are not using this mode. But so what is the function of this mode? So it will deliver the assisted breath and it allows the patient to breathe. Then the patient is breathing, so this will be stop giving the breaths, and whenever again the patient is dull or when he's not able to take the breath, again it will initiate the breath. That is the difference between SIV and assisted control mode. So assisted control always delivers the ventilator, like tidal volume, respiratory rate, and it supports the patient's breath. But SIV mode, it delivers, but when a patient is giving the breath, it will stop. Am I clear with the difference between AC mode and SIV mode? Yes. Next is PSV mode. PSV mode, pressure support ventilation mode. So in this ventilator, both ventilator and patients are friends. So here the control is done by the patients, and usually this mode we will keep to wean off the patient, to wean off the ventilator. To clear understand, the main concept I have taken an example of a husband and wife. So I think this will be a clear example for you. So husband and wife, husband is a ventilator and a wife is a patient, for example. So in CME mode, completely dominated by the husband and there is no role of a wife. So always the wife depending on the husband. So this is CME mode. Coming to assisted control mode, the husband is giving some support for the patient, for the wife. So when a wife is not, when the wife is giving some advices or some ideas, so always he will cooperate and he will support it. Then coming to SIV mode, completely he is dependent. So when a wife is giving some advices, so what happens here? So the husband will be okay. He will give chances for the wife to perform any work. But when a wife requires a support, immediately husband will give. So this is SIV mode. And PSV, they are both are friends. They are having an equal chances in everything, and the domination will be by the wife. Am I clear with the four modes with a simple example, wife and husband? Yes. Next, so this I'm not going to explain complete. So this is a table where you need to understand for which condition you need to keep the mode and the respiratory breaths and tidal volume FiO2 and P. So you can take a screenshot of this because it is very useful for you. Mostly the doctors plays a major role in setting the ventilator mode and everything, but it is a responsibility of a nurse to understand what is this guidelines that we are following for setting the ventilator in different disease conditions. Can change it. Then red flags. So what is the red flags? Always it says, it indicates alarms, warning. So when a warning is given, so what you will do? Immediately you will go away from that warning? No. So what you need to do is alarms. So when there is a ventilator alarms, what you should do as a nurse, what is your management? Next is VAE bundle. VAE is ventilator associated events and bundle. So we used to have a VAP bundle, that is ventilator associated pneumonia, and what we need to do to prevent the pneumonia. Now it was changed to VAE bundle. Now we'll look into each alarms and I'll tell you the responsibility of a nurse. The first alarm is high pressure alarm. Why a patient will get a high pressure alarm on a ventilator? Why? Anyone who can text me? So why we will get a high pressure alarm? See, so high pressure means when there is any problem, so there is when a ventilator is giving the volume and the pressure is too much so that it is not able to ventilate the patient. That time you are able to get the high pressure alarm. So whenever you are seeing an alarm, you need to assess externally and internally. So externally, you have to start from the circuits, so ventilator circuit, to check whether there is any water in the ventilator circuit. No water, again you need to go with the humidifier. Is there any secretions in the humidifier, or it is contaminated? No problem in the humidifier, then go with the ED tube. So whether the patient has biter, or if there is any leakage, then you need to, if there is no problem externally, then the problem will be inside. Inside in the sense, the tube may be advanced into the right bronchus, or patient may have a tension pneumothorax or bronchospasm. The first initial role is to understand why the alarms are there on the monitor. But we used to do, so when there is an alarm was beeping in the monitor, definitely you will go and you will just go with the silence alarm, but we'll never identify why that alarm is. But it is an important role of a nurse to identify why there is an alarm displayed on the monitor. The next is a low pressure alarm. This pressure alarm will happen when there is a disconnection of the tubings and there is a leak in the cuff or a humidifier. Next is a high respiratory rate alarm. So this will happen when a patient is having anxiety or pain. So pain, we can't see. When the patient is having pain inside, he has to tell you, right? So when he was sedated, so we can be recognized by high pressure alarm and the anxiety. Though it is a fever and everything, also you will get the higher respiratory rate alarm. The next alarm is the oxygen and apnea. When there is an insufficiency of oxygen, immediately you will get this alarm. And apnea, when a ventilator is not able to give an adequate amount of breaths or the ventilation, you will get this alarm. Am I clear with all the alarms and it causes? Yes. So what you should do, then there is an alarm. So this is a simple flow chart where you can understand what is the responsibility of a nurse. So here, see, when a patient is having a high peak airway pressure alarm and minute ventilation is inadequate, again, you first check the potential causes, why it is happening. Then, so you can understand when you see, then you have to go with the action. First, you need to immediately disconnect the patient from the ventilator and back with 100% of oxygen. That is through ambu bag or through the vein circuits, you have to give 100% of oxygen. While you're giving this oxygen, so what happens if you're not able to bag? So when you're pushing this air and the balloon is not able to push hardly and you have some obstruction or resistance is coming, that means there is obstruction somewhere. If you're feeling any obstruction while giving a bag, then you try to insert a catheter. When a catheter you are inserting, if it is easy going, then okay, it may be a problem with internal beings. But if there is no, when this catheter is not inserted and it is obstructed, it may be because of this biting or there is an occlusion in the ET tube and maybe the malposing. These are the main causes of this. So when it was advanced, so what do you have to do? The potential causes you need to check and you need to examine. So this is the main important role of a nurse. So you have to examine through auscultation, check the lungs if there is any wheezing sound and the bilateral entry of the air is present. Bilateral means to the right and to the left. The equal distribution of air is present or not, that you need to check while examining the patient. And after examination, inform to the doctor that these are the things that had happened to the patient and immediately follow whatever the doctor has advised. If they are advising bronchodilator, please don't miss any administration of drug. Immediately you have to initiate it and you have to start administering drug. And if the doctor's advice for emergency bronchoscopy or drain placement, make arrangement as soon as possible and you should be alert and keep at the patient bedside for easy access and never miss any articles while doing this process. Is it clear with the responsibility of a nurse when you are taking care of a patient on ventilator? Any doubts with the troubleshooting approach? Any doubts? Am I clear or you want me to tell this? Okay, fine. So let's move on to this. Most important thing is the ventilator associated events. That is the care bundle taken by the nurses. The first thing is to change position. Is it important for a nurse to change position? Why we are changing position for a patient? Yes, so we need to change the position. So always you need to elevate the head end to 35 degrees, but not in supine position. What happens if the patient is supine position? The air entry is not inadequate. So for example, if you're sleeping on the bed, so normal persons without any defects, you can't breathe properly when you are in supine position. Immediately you will change the position from right to left, or you will sit sometimes. So why? Because you're not able to ventilate the alveoli. The same here for a patient who has a disease can't tolerate a supine position. So when you're making the patients to elevate the head to 30 degrees, so what happens? The gravity will help in pulling the air that you're giving from the ventilator. That is the main advantage of semi-follows or elevation of the head to 30 degrees. Second one is a prone position. Why we are preferring? So mostly during the pandemic situation, during COVID, so what happens? We have taken the patients and we are proning the patients. Why this is happening? Why we have to prone the patient? For example, take a sponge. Have seen this to clean the vessels. We have a sponge, right? The soft one. So when you keep the sponge, so you just you have dip in the water and you take it and you keep it on a flat surface. So what happens? The water ultimately settles down. And again, when you shift towards it, the water that is there on the surface, again, it will come down and settle down. So this is same thing happens when you change the position of the patient from supine to prone and prone to position, so that there is an equal distribution of oxygen from the anterior to the posterior and posterior to the anterior. Am I clear with this change of position? Yes, so position change is very important to ventilate the patient. The second one is PUD, that is peptic ulcer disease. So peptic ulcer disease, so because of when a patient is on ventilator, we'll give an n number of drugs like antibiotics, so everything, antibiotic sedations, and some other medications where you will give for the patients to treat the condition. So what happens? Ultimately, the layer of the stomach will be will be damaged. So that may lead to peptic ulcer. To protect the gastric layer, so we will give an antacids to treat the patient. Next is a oral care. So always remember, every second hourly, please do oral hygiene for the patients in order to protect it with 0.2% chlorhexidine solution. Next is a subglottic suction. Here is a question for you again. So subglottic suction, is it an open suction method or a closed suction? Is this subglottic suction is an open or closed? Yes. Many have answered yes. It is a closed suction, but not an open suction. Okay. So why? Because it is continuously connected to the suction, and you are continuously, if there is any secretions, you just on it and you will be suctioning by giving the force. Clear? So that the infection rate for the patient will be reduced and you are protecting the lungs of the patient. Next, DVT prophylaxis. Why DVT prophylaxis? We have to learn here. So when a patient is on the bed for prolonged time, so what happens? Again, the gravity works. So when the gravity, so what happens? The blood will come and settle in the lower extremities, which may lead to forming of blood clots in the lower extremities. So to prevent that, we need to follow DVT prophylaxis. So this DVT prophylaxis can be done in two ways, chemically and mechanically. So chemically, we can administer anticoagulants, and mechanically, we can use the stockings or flutron mission, so that in the flutron mission, we'll adjust the pressure. 40 mm of Hg, it will inflate, and with 50 mm of Hg, it will deflate. So inflation and deflation alternatively will help in improving the circulation to the lower extremities. Further, we are preventing DVT prophylaxis. Am I clear with this? Am I clear with this? Okay. Next is a cuff pressure manometer. Always remember that cuff pressure should be maintained for 20 to 30 centimeters of water. Why? Again, why we require a pressure? Because if this pressure is not maintained, ultimately this cuff will be leaked and the tube will be string and it will slip into the right bronchus or to the left bronchus, wherever it is. Or it may be just coming out of the tube. It doesn't happen, but sometimes maybe it can be disconnected or misplaced from the position. So these are the care bundles that you need to keep in mind whenever you are taking care of a patient with ventilator. Complications. Why a patient will get a complications when you're treating so properly? right? So if you are treating the patient accurately, following all the parameters, the settings of the ventilator is adequate, you're following the WAP bundle, you know how to, when there is alarm, you alert it, then there will be no complications. But when you are neglecting or even a small mistakes can lead to a complication, like biotrauma, barotrauma, atelectasis, WAP, sepsis. So these are the 5 complications where a patient can encounter if a patient is on ventilator. In a nutshell, mechanical ventilation is a life-saving intervention which requires multidisciplinary team effort to prevent adverse effects of ventilator. Nurses have a key role to prevent patients from prolonged hospital stay by providing quality nursing care. So am I clear with the ventilator? If everyone has understood, I have a scenario with me. So everyone understood about the ventilator? Then let's move on to this scenario. Okay, so you are a nurse looking after a patient who is 70 years old, male patient in ICU. He came with the complaints of SOB orthopnea with pedal edema, and the patient is on NIV support, that is BiPAP. On day 2, so what happens to the patients here? The saturation levels dropped. Vital signs were recorded as heart rate 120 beats per minute, respiratory rate 30 beats per minute, blood pressure 160 by 80 mm of Hg. So immediately patient was intubated by the doctors and kept on assisted control mode with PEEP 8, respiratory rate 80, FiO2 100. So after a couple of hours after intubation, you have seen on the monitor high pressure alarm. Remember, after a couple of hours of intubation, you have seen on the screen high pressure alarm. What is your responsibility? What is your immediate responsibility? Can anyone? Okay, so first step, there are 3 steps as I told you. The first thing is check for the possible causes. So why a ventilator is there? Next, you have to silence the alarm and treat accordingly. For example, high pressure alarm, maybe there is a mucus plug. If there is a mucus plug, again, you have to do suctioning. If there is any secretions or if there is any tube or water in the tube, so what you will do? You bag the patient and remove the ventilator circuit, whatever it is there in the water, you have to remove it. So this is your interventions and treat the patient accordingly and immediately inform to the doctor. So this is how you need to manage when you are taking care of a patient in ICU with a ventilator. Any doubts? Any doubts about the session? Am I clear? So I'm ending the session. Thank you so much.
Hello. Thank you, Yojana. You have done this session very interesting, and actually you made it very simple and understandable. So we try to keep it very simple so that audience can follow it up. So we possibly try to take it one more series on the ventilator as per requesting on everyone. And please watch till the end where there is a surprise from this webinar. So please continue watching. As our expert panelist, Dr. Abhishek is with us. He would like to just overview on the importance of knowing ventilators, life-saving equipments. As a staff nurse, you should know. Just I would like to hand over this to our Dr. Abhishek.
Thank you, Dr. Thomas, sir, and thank you, Yojana. It was a very nice presentation. She covered almost everything in a very systemic manner. So first, I would like to highlight a few points here for the critical care nursing staff. So as we know, we have almost 30 to 50% of the patients on ventilator in our ICU. At least 30 and 25% of the patients will be on a ventilator. So it is important, first it's important to identify the patients who require a mechanical ventilation. So as she rightly said, all the patients who are in respiratory distress, in spite of being on oxygen, who are dropping their saturations, then you should alert the doctors, because doctors may be seeing other patients. So you should alert them so that the patient will be intubated in the right time, because delay in intubation itself will increase the mortality. So rightly identifying the patients who require the mechanical ventilation is the first important step. Okay. Then then again, coming now, she spoke very nicely about the modes of ventilation. So I would say to just give a overview for all these points. Volume control, in assist control mode, the volume control mode is the most preferred. It is the most studied, and it's a less complex method of ventilation. Here you just need to set the tidal volume. So whatever anything may go wrong, but the preset tidal volume will be delivered to the patient. So in a way, it is a very safe medication. So even sometimes if when the doctor is not around, if you want to set these patients on a volume control mode, because it's the safest of the methods or the other methods. And as she again told, pressure support mode, you just 100%, then you have to taper based on the target. Okay, respiratory rate of 14 and initial PEEP of 6. You set the initial, you put the settings, and after that, based on the patient's response, it's the doctor's responsibility to adjust the settings, right? The most important thing is, before connecting the ventilator, please set all the alarms. There will be specific alarms which you have to set. Generally, you have to set 20% above and 20% below the normal preferred thing. So when suppose if the pressures go 20% above what you set, and if it falls 20% below what you set, then it raises the alarm, so you can be activated with that. So generally, what commonly we see in our ICU patients which cause alarms is, first is accidental extubation, accidental dislodgement of tube, or endotracheal tube blocks, okay, or endobronchial intubation, or apnea alarms. These are very commonly seen. So in all these problems, you see a increased, most of the times you see an increased peak airway pressures. So during these times, she was also mentioning how to troubleshoot when there's increased pressure alarms. So you need to alert the doctor. You also need to make your own assessment. Like you have to auscultate the patient's lungs, right? And you need to again look at the ventilator. You need to suction the endotracheal tube. So by the time doctor comes, you should have your own suspicion, so that you can help the doctor in dealing with it, right? And just after putting the patient on ventilator, the most important part comes here, because ventilator itself has a lot, as she rightly said, there are a lot of complications with ventilator. So first of all, first let us talk about the complication. Not only it has like ventilator acquired events like ventilator associated pneumonias. Not only that, even any patient on ventilator, they tend to have low blood pressures also, and the require sedation as long as they're on ventilator. Again, sedation has its own effects. Right, and to continue a patient on a ventilator. So our goal should be to remove the ventilator from the patient as early as possible, to start weaning as soon as possible. That can be possible only by two things. First, of course, we have to treat the primary condition, and second thing is we have to take measures to prevent the ventilator associated complications, right? So not only nursing staff, also doctors, whoever is working in ICU, like paramedical or house cleaning staff, everyone should be aware of this VAP bundle, right? That this is a cornerstone, this is a mainstay to prevent the ventilator associated pneumonias. So she clearly has shown you all the slides about how we should follow the associated events. So if you ask me, this is the most important thing. One should be very strict in following the VAP bundle, because by preventing the ventilator associated infections, pneumonias, you can definitely extubate the patients, I mean, wean the patients early and prevent the long ICU stays and further complications. And it has clearly shown that if we follow these bundles, the mortality, that means the death rate is also can also be significantly reduced, right? So that's it. And one more thing, weaning. I would also like to emphasize on weaning. Any patient on a ventilator every day, every next day, if you feel the, I mean, you have to discuss with the treating doctor, the treating intensivist, that, sir, like, do you think the patient condition is improving? Is the disease getting better? Is there a chance to start weaning this patient? So every day we have to assess for the weaning. Okay, you have to discuss with the doctor, like, is this patient ready to wean? Because the early we wean, the early we can prevent the ventilator associated infections, and the better will be the mortality. So once again, I would like to congratulate and thank Yojana for an excellent presentation. And thank you for giving me this opportunity. Thank you.
Thank you, sir, for just giving the overview on the basic modes, ventilators, and how a staff nurse should be aware of in emergencies, how to attend the alarms, how to attend the early warning sign, all those things. So I would like to take on Dr. Pratusha would like to say something about this webinars. Yeah, please come.
Hi, everyone. And Yashoda Hospitals have got you a surprise gift, because we have seen so many people are trying to connect since from the starting till the end of the webinar. So hence what we thought is we wanted to thank you all people with a surprise gift. And here is a surprise gift. Every week we wanted to announce, we wanted to select a winner who is very active and completely continuing throughout the seminar, and also trying to connect with the speaker whenever they ask you the questions, and you are trying to answer, and you are trying to make the answers to be reliant. So here we are going to select the active participants, and we are going to announce every week the winners. So today's webinar is also a surprise. So here we are going to select the winner for this week, and we are going to announce the winners for the next webinar. So please do connect in the next webinar to grab your gift. I hope you all will connect in the next webinar and you will enjoy the gift. Make the suspense throughout the next week also, and please do connect on the next Friday 3 p.m. sharp. At the end of the webinar, we are going to announce the winner, so please don't miss the connect. And we are going to see the timeline, how much time you have connected with us since from the starting till the end. And also we wanted to mention a small thing. You have liked our webinars and you want to share it throughout the media. So please do hashtag Yashoda Hospitals and do share in your Instagram, Facebook, and also into the YouTube, so that you can also get the other participants can also come and watch these webinars, which are so informative and which we are trying to put our efforts to make the nurses to understand and take this platform as a educational platform where everyone are not getting this. So we thank Yashoda Hospitals for giving us this opportunity, and we'll be waiting for the next super surprising announcement webinar. Thank you, sir.
Thank you, Pratusha. The main motto of doing this webinars is to make as much as possible to reach out the maximum people who cannot come and connect with us. We're trying to teach them, everyone who are like in critical care, in healthcare industry, everyone, getting time is very difficult in the same time. So this is the best way to get connecting wherever you are. So be connected every Friday, 3 p.m. Thank you. Thank you so much. Thank you, Ojana. Thank you, Pratusha. Thank you, Dr. Abhishek. So thank you. Bye.